How's it going, friends? Nurse V here. So, today we are going to focus on a nursing topic, which by the title may sound silly to those who have been in the nursing profession for such a long time, but this particular video is catered to pre-nursing students, nursing students, new nurses, or honestly, really anybody who want to kind of just really hone down on the fundamentals. But this video in particular is also another opportunity for me to really kind of focus on fundamental cardiac topics and then kind of branch out into something a little bit more advanced. So today we're going to talk about how to listen to heart sounds. How do we auscultate them? For somebody who works in a cardiac environment, I use the stethoscope pretty much almost every working day, right? And I kind of want to just talk about proper placements, what exactly we're listening for, and even talk about some of the fun stuff about, the history of stethoscopes and how it eventually branched out to what it is today. So grab a stethoscope and let's get right into it. So let's just dive right into the history. So René Laennec, I believe I'm saying his name right. René Laennec, born in 1781 to 1826, he was a French physician who created the stethoscope in 1816, where he and another physician was essentially watching two kids. There were two kids playing and talking with each other with these like long pieces of wooden pin, kind of like, you know how you grab like a can and you tie it to a string and you have the other person kind of go a couple of feet away and then you try to talk into it? That's what they were watching. So they were watching these two kids playing, and inspired by, this kind of interesting entrapment to be able to magnify sounds, he blueprinted his very own first stethoscope, which was comprised of a wooden cylinder and a funnel-shaped cavity that just kind of really helped to amplify the sound. So because of his invention, allowed himself to discern many types of pulmonary sounds such as rales, bronchi, and even classifying pulmonary diseases such as pneumonia, emphysema, pneumothorax, etc. Ironically, unfortunately, he died of tuberculosis and was unable to just witness how his stethoscopes have evolved over the years. So now fast forward over to 1851, an Irish physician by the name of Arthur Leard was known for the creation of the binaural stethoscope, which takes a lot of resemblance of the stethoscopes today that we're using. What makes it different from the previous stethoscope is that he actually replaced this wooden cylinder to something now for more of a rubber tubing. So now let's go ahead and talk about the anatomy of the stethoscope. Starting from the top, we have the following. We got the ear tips, we got the headset, that's where the ear tips are connected. We got the ear tube, where sounds travel from the chest piece, that's where the rubber and the metal meets. And then we got the tubing, where the sound travels. Now, there's a single lumen versus a double lumen. The single lumen has one tubing that extends from the chest tube and then splits into two individual tubes. And then you got the double lumen, which has two tubes, connects from the chest tube and then splits into two, in which each tube goes into each ear. My recommendation is to get the double lumen first, especially if nursing is new to you. Some will say, not to spend a lot of money on a stethoscope when you start out, but I will rebuke by saying having a strong stethoscope allows you to really develop that strong fundamental in learning to recognize different heart and lung sounds. So the one that I'm currently using, it's a Littman Cardiology IV, and it's been my working horse ever since clinical days. So now the chest piece, it has the diaphragm and the bell. And the diaphragm typically is for the medium pitch, and oftentimes I will use this when working with adult patients. But if you have a hard time hearing, then just go ahead and use the bell, which is the small piece, and it's really made to pick up lower pitch sounds like a heart murmur. Just one thing to remind you is that our job as a nurse is not to diagnose murmur or any other funky sounds. But my advice is if you auscultate and you hear something that doesn't sound normal to you, then I would just go ahead and look at your doctor's notes, right? Either your hospitalist, your cardiologist, whoever physicians you're working with. Look at the notes to see if they have acknowledged those abnormal sounds, and it's documented, okay? And if it's not, then, you can go ahead and talk to your provider and say like, hey, I heard this patient has a murmur. Do you want to come in and confirm? Just go ahead and double check with your physician too. But like I say, just always double check your documentations just to make sure that this has been acknowledged. All right, so let's talk about how do we wear the stethoscope. All right, so, the classic stethoscope around the neck. One thing I want to just kind of warn you is be very mindful of your surroundings, be very mindful of your patients. If your patient has a history of violent, or even if the patient is being aggravated or is a violent patient, you always want to make sure that you protect your safety first, okay? I know this video isn't about, safety and whatnot, but so much of nursing is about protecting yourself and the patient, right? So always have the stethoscope out of your neck, because this is a perfect tool for strangulations and you would be completely out for the entire shift. Okay, so that's just rule of thumb. But listening or wearing the stethoscope, you put it around your neck, okay? Now, when you put it onto your ear, this is a classic mistake that I myself make all the time, especially when I'm rushing or when I'm just not, I'm just being completely derpy. You always want to make sure that when you're about to put the stethoscope into your ear, that you have the earpiece pointing towards your patient. All right, so next we're going to talk about heart sound location. So there are 5 auscultation points on the chest where you can listen to the different valves of the heart, okay? So each of these 5 locations are the aortic, the pulmonic, the Erb's point, tricuspid, and the mitral. And if you have a hard time remembering like I do, right, just remember this quotations or this mnemonic or what have you is all people enjoy Time magazine, okay? All people enjoy Time magazine. Aortic, pulmonic, Erb's point, tricuspid, mitral, all people enjoy Time magazine. Now, if you recall in a normal heartbeat, we have the S1 and the S2, okay? So the S1 and the S2 is responsible for the quote-unquote lub-dub sound. The S1 being the lub sound, that represents the closing of both the mitral and the tricuspid valve. And then the S2 being the dub sound, that represents the closing of the aortic and the pulmonic valve, okay? So in this video, I'll be using the S1 or lub and the S2 or dub interchangeably, okay? They mean the same thing for this video. All right, so let's go ahead and start with our first one, the aortic. So the aortic is located at the right second intercostal space. So you'll hear an S2 sound or a dub, okay? That means that the aortic and the pulmonic valve, they're essentially closing, okay? So now the pulmonic, that's actually located on the left second intercostal space, and that's similar to the previous. You'll also hear an S2 or a dub sound due to both the aortic and pulmonic valve closing. Now let's go ahead and talk about the Erb's point. So the Erb's point, okay, is located on the third intercostal space, and that's where you can hear both the S1 and the S2 sound. The tricuspid is located on the fourth left intercostal space, and that's where you hear the S1 or the lub sound of both the mitral and the tricuspid valve closing. And then finally, the mitral valve located on the fifth left intercostal space, and that's where you hear the S1 or the lub sound of both the mitral and the tricuspid valve closing as well. Okay, so just to kind of recap what I just mentioned, because I know I'm just kind of talking at you, but really what it is that the aortic and the pulmonic, you'll hear the S2 sound, which is the dub sound, and then the tricuspid and the mitral valve, you hear the S1 sound, which is the lub sound. So when I say S1, lub sound, you're gonna find those on the tricuspid or the mitral valve side. And then if you hear the S2 sound or the dub sound, you hear it on the aortic and the pulmonic sound. And then finally, the Erb's point, which is located kind of like right in the center on the third intercostal space. That's when you can actually hear both the S1 and the S2 sound, okay? Now, S3 and S4, which I'm sure some of you have already heard if you're very new into this, the S3 and the S4, they're essentially just both abnormal heart sounds, both of which indicates that there is some type of like resistance during systole or diastole, which is the contraction and the relaxation of the heart. But you know, for the sake of this video, I'm gonna make that a separate thing, a later video for a future to cover about abnormal heart sounds. But for now, just focus on familiarizing yourself with your stethoscope, how to properly wear it, learn about the 5-point location and how these locations represents the various valves closing. So we won't talk about the pathophysiology of different heart sounds, like the S3 and the S4. Right now, we're just kind of focused on kind of like the expected, anticipated heart sounds. So the approach, okay? So we learn about the different heart sounds, we learn about the anatomy of the stethoscope. Let's talk about how do we actually approach the patients and listen, okay? A hospital isn't gonna be completely silent, but what I would do is, I will walk up to my patient, I will tell them, hey, how's it going? I'm here to listen to your heart and lungs. Just be very aware of your surroundings. If a patient is like listening to something very loud, like if they're listening to a radio or they're watching TV or something, just tell them I'm just gonna mute it. I'm gonna turn off just briefly because I need to get a good listen, okay? If you know that you're working with a patient who is lethargic and is resistant to sitting up or turning or things of that sort, collaborate, okay? Collaborate with your CNAs, your techs, collaborate with your physical therapists, right? Because eventually they're going to have to ambulate, right? So to prevent, the patient from hurting themselves, ideally we want them to be able to move on their own. But if you're really trying to cluster your care, collaborate with your nurse tech, right? Or your CNA and be like, hey, are you doing a bed change or are you changing the patients? Do you mind if I come in there with you so that I can help change the patients and also listen to your heart and lungs? Boom. So you just always want to make sure that you communicate to your team so that you can really get a good assessment in without like having to interrupt the patient, right? Because they need to rest too. So there you have it. That is how we listen, how we auscultate heart sounds. Hopefully that helps. I know some of you who are watching this may have years of experience into nursing, or some of you are starting. Whatever level you may be, I hope this video is helpful for you to learn how to properly auscultate your patient. And hopefully you'll share this video, I don't know, and in due time.